Thank you very much, Dr. Farkade. Good morning. I think we've been running after time. I think everyone's tired. But let's take a deep breath and relax. We're pediatricians, we're with you, and we like to tell stories. So I'm going to tell you a story today about Alagille. These are my disclosures. And honestly, my main objective is to encourage us to collect our data and look at our patients differently. We're going to discuss strategies to, diagnose Alagille, referring process, and enhance the management of Alagille syndrome in Saudi Arabia. So كان مكان في قديم الزمان in 1969, 10 years before I was born. There was this very curious physician who looked into his patients differently in a different eye. And he noticed that he'd seen a subset of patients who had arterial hepatic manifestation, systemic manifestation, and he had a friend who's called Watson. And he was also looking at the same patient population. And together, they kind of defined a syndrome that was called arteriohepatic dysplasia. And then the genetic testing came. And then they discovered in 1997 the JAK gene. And then at the end of early 2004 and 6, they discovered the Notch gene. And with all the progress of all these people around the world, from genetic, pharmaceutical, metabolic, pediatricians, cardiologists, liver transplant surgeons, for 55 years, we are working now all over the world to take care of these patients with very rare liver diseases, including Alagille. And now we are very privileged, and our patients are very privileged to have actually medications that actually can treat and improve the quality of life of patients with Alagille syndrome. This picture is for you to see that publications on Alagille are very scarce, and they're mainly from the West and the East. And we have very few publications from the Middle East, from Saudi Arabia, from Qatar, from Kuwait. So our patients, as Dr. Amal said, we do have a different genetic landscape. And we do have different population. And if I can ask you, just when you look at your patient, just try to compare them. Do they look any different? Do a combined gene gives a different presentation? Do we have the same genetic, is truly JAG1 more common than Notch2 here in the Middle East? So Alagille, as we all know, is a multisystemic autosomal dominant disease with predominantly hepatic manifestation. It's sporadic. 60% of the patient had family history present. Some mutations were associated in wide range of, some different mutation had different association and wide range of clinical finding. Other conditions can also look like Alagille. Other conditions cause bile duct opacity, cystic fibrosis, drug, virus, sclerosing cholangitis, and there's a lot of overlapping features with other diseases like PFIC and biliary atresia. So, significantly, we see that patients with Notch2 mutations has less of the extrahepatic features compared to the JAG1. So it's much easier to misdiagnose patients with Notch2 mutations. Until now, there's no known correlation between the genotype and phenotype, and the clinical manifestation can range from 0 to multiple. And I'm sure you all know about the facial features, the vascular finding, the liver vertebra, butterfly vertebra, the cardiac defects, and all the kidney and eye manifestation of Alagille. So here I want to tell you that most of the presentation are hepatic and cardiac abnormalities. Up to 90 to 95% of patients will have both hepatic and cardiac abnormalities, and the rest depending on the patient. And you have to be looking for these findings. It's very important not to miss the diagnosis, and we have to double check ourselves. With our guidelines right now, we still have a chance to miss a diagnosis of Alagille patient, confuse them with a PFIC3 or a biliary atresia, even with a liver biopsy, even with the typical cholestatic workup that we do. It's very important to do that because an inappropriate KSA actually has worse outcomes. Alagille patients who undergo KSA operation versus those who did not go into an KSA operation have 26 times higher risk of not living with their native liver, and they have 15 times higher risk of mortality. So this is a big price to pay if we're not careful enough. How common is Alagille? It's estimated worldwide 1 in 30 to 50,000 live births. The prevalence varies globally. We don't have accurate numbers here in the Middle East. It's likely due to underdiagnosis and a variable clinical presentation. Why is it important to diagnose these patients? It's not just the liver. These kids with cholestatic liver disease have very poor quality of life. And here in Saudi Arabia, you can see that we have the public sector and the private sector, 80 to 70 public and 30% sector. And even the public is fragmented. Ministry of Defense, Interior, Education, National Healthcare. And we are working on the vision to provide a model of care for our patient that creates a referral system that provides the best access and outcome for our patients. But until we go there, we have to work together and create the best outcomes for our patient. These patients utilize the healthcare system in a very large way. They have multiple visits, inpatient, outpatient. The healthcare expenses for these patients are very, very high. So here's what we know. We know that we want to organize patient care around these patients. We want to serve them to achieve better results. We want to uncover unmet needs. We need to identify obstacles in health, and we may make sure that no patient falls through the crack. We have sat 2 years ago with hepatologists from all over the country, east, west, middle, and we thought that let's see, how many patients do we get per year. We usually, a physician would get 1 patient per year, maximum 2, with confirmed genetic testing of Alagille. Genetic access is variable. It's good, but it's still variable. And 97% of these patients had JAG mutation. 3% had Notch mutation. And out of the cholestatic infants, only 3.5% were diagnosed with Alagille syndrome. Patients were managed by conventional therapy, and some were sent to transplant. And also pediatric cardiologists are one of the physicians that see a lot of our Alagille patients. Patients have inherited Alagille, more common than de novo, and they usually get the liver transplantation early in life. Some get it around 18 to 20 years. And a lot of 10 to 20% of our Alagille patients will have renal involvement. It's very important that we can improve the care for Alagille syndrome in Saudi Arabia. We have to consider the diagnosis. We have to think about it and send for it. We have to, as we're doing right now, hold continuous medical education to improve the awareness for Alagille among the pediatricians. So we have to support local research data from the institutions, from the pharmatech, from the academics. We have to improve, establish national registry in Saudi Arabia and continue to collect data on our patients. Post-market analysis after the IBAT inhibitors is now invading the market. These are my 9 patients. I've been working here for 9 years. I get one patient a year. 5 of my 4 patients had JAG1 mutation. 6 males, 3 females. None of them had family history. Unfortunately, I was not able to do the paternal, check if it's had de novo mutations or not. 4 of them had liver transplant. This is biased. I'm a transplant center, so I get patients for transplant all the time. What I want you to notice that the patients with JAG1 mutation had much more extrahepatic manifestation. Notch2 mutations had barely nothing other than pruritus. One of them had dextrocardia and had a liver biopsy that confirmed biliary atresia. And this patient went and had KSA and had the entire full evidence-based practice. If I'm not the person who would double-check myself, I have decided to send genetic testing on every patient that comes to me. I want to make sure I'm not missing. And this patient actually had a Notch2 mutation. Am I ashamed? No. I'm proud. I'm proud that I'm able to double-check myself. Yes, this patient may have worse outcome, but this patient will help me take care of future patients. Dr. Kumar, thank you. Where are you? Thank you, thank you. He sent me the slide yesterday at 3 p.m. Dr. Shagarani, come on, thank you. These are your patients. 56 Alagille patients, 32 post-liver transplant, and 47 with JAG1 mutation. Only 5 notches. I had 4 notches. I don't know why. Is it the Eastern Province? Is it the North? Maybe we can have more answers in the future. 4 of them had de novo mutations. They're lucky to have Satish. I don't. Globally, global rates of native river survival, at 18 years of age is 40%. And cumulative incidence of liver transplant or death, it's up to, by 18 years, is 50 to 60%. So that's a big problem. Children with Alagille who had total serum bilirubin level above less than 5 at age 6 to 12 months had significantly higher rates of native liver survival compared to those who had more than 5. So these patients will eventually, at some point of time, need liver transplant. And the main indication for liver transplant is intractable pruritus, growth failures. Of course, on top of what we already know, cirrhosis, portal hypertension, and fat cellular vitamin deficiency. If we can prevent, Dr. Gahtani, prevent transplant, that's our success as pediatricians. Yes, we are, nowadays, we want a liver transplant. It's a life-saving patient, but if I can delay a liver transplant for a patient a year or 10, that's an extra year or 10 on the other side of the liver transplant. We transplant patients at 5 years of age. They're not 60, they're not 65, they're 1 year of age. I want them to live for 70 years. Okay, so that's 70 years of a single liver. So that's a lot of work. That's my work, your work, surgeon's work, parental work, adult hepatologist work. We all need to work together. It's a different, we're not comparing apples to oranges. It's a different liver transplant, word in pediatrics. So liver transplant is a big surgical procedure. You have immune suppression for life. You have multisystemic renal, cardiac, vascular involvement. You have to make sure, check an MRI. Most of the patients are transplanted earlier in life. 72% are transplanted in the first 5 years of age. And we know the cholestatic pruritus management from the EASL guidelines. We had the Urson, the rifampin, cut your nails, but we're very lucky right now to have the IBAT inhibitors that came into the field to help the quality of life of patients with cholestatic pruritus, Alagille, and PFIX. The IBAT inhibitors work on the IBAT. They inhibit the absorption of bile acid from the terminal ileum. And are they effective? I think they are. We have two big medications, the odevixibat and the marixabat. The main big trials were phase 2 and phase 3 trial. We have placebo-controlled randomized double-blinded ASSERT study with a 24-week study duration and a long-term extend 72 weeks. This medication is compared to marixabat, the iconic phase 2 trial. This study was a double-blind placebo randomized drug withdrawal period, and they both reached the end result. So just for the sake of time, I will show you that the change in serum bile acids with the odevixibat at 24 they divided the patients to placebo and medication trial, and you can see that the placebo patient had higher serum bile acid levels, and that level decreased as soon as they started on odevixibat. And the serum bile acid level also converts to the level of pruritus that has decreased. And also, odevixibat is, the IBATs are associated with improved quality of life, improved sleep for the parents and the patients, with days of more sleep and less soothing from the parent side. Also improved in quality of life and all aspects of life: physical function, emotional function, social, school functions. And these medications have very low side effect profile, mainly diarrhea, and they're very safe to use. Same thing with marixabat. At the time of the withdrawal, you can see that the bile acid and the itching has increased for both patients. And also with the same safety profile, the main side effect is diarrhea, some GI upset. And this is a paper that I just found recently. This is a review to confirm that the substantial clinical, economic, and health quality-related burden associated with Alagille, consolidated current treatment evidence. The data from these studies demonstrate that the impact of IBAT inhibitors transforms life by improving cholestatic pruritus, quality of life, and improve the natural liver survival. And also, despite the expenses of these medication. So I think I will finish on time. These are our 2 medications. How to identify the right patient for these 2 medications. Odebexabat is approved for patient more than 6 months. Marlexabat is for patient more than 2 months. One is granules, one is liquid, and they have dosing charts that you can do. You can do them once in the morning, with or without food. Marlexabat is 30 minutes before meal. And finally, Alagille, as we all know, is a multisystemic disorder, dominantly liver disease. We have to improve diagnostic accuracy and establish patient-centered care for these patients. Please, please collect data on your patient. Look at them differently. We have a different genetic landscape here in Saudi Arabia. It takes a village to take care of patients with cholestatic liver disease. We work here together to do that. Thank you very, very much.
Thank you very much for this comprehensive overview of the disease and the new treatments. The paper is open for discussion.